This is a live recording from Radiopedia.org's 2015 Emergency Radiology course in Melbourne, Australia, featuring Dr. Andrew Dixon and Dr. Frank Gaylard. For more information about Radiopedia courses, visit radiopedia.org/courses.
Thank you all very much for coming. My name's Andrew Dixon. We're filming today's course and it's going to be seen in 115 developing countries for free. And so we can only do that because we have people physically coming and attending the course. So thank you very much for spending a little bit of money to come along here so that other people can get some education for free. It's $25 in all other countries in the world as well. So what you're doing here by coming along is really supporting us. I've got two guests with me here today. We've got Frank Gaylard, who is the founder and editor-in-chief of Radiopedia. He's a neuroradiologist at Royal Melbourne Hospital, and he's going to be presenting the final session. We have Andy Buck, who's an emergency physician. He runs a trauma management course here in Melbourne, which is also all around the country. He's just going to be adding a little bit of an emergency physician perspective to the whole thing. Here we go. So I just wanted to get an idea of where everyone's at. We have one Yoda. Where's Yoda? Oh, Frank. Such arrogance. Well, I tell you what, if we have any cases that people can't get today, we'll throw them to Frank, because he's Yoda, and he should be able to get every single one right. Okay, so that seems to be working. The live poll, it will just update automatically on your phone. You don't need to do anything. If you find that it's not working, just click refresh. So we're starting with upper limb first, and start kind of from proximal and work our way distally. With the clavicle fractures, no one ever comes and asks me about clavicle fractures because clavicle fractures are easy. So we're not going to talk much about them. The main things to notice are if it's really angulated, like this case up here, or if it's really displaced and comminuted, then the surgeon is probably going to go and put a plate and fix it. If it's not too displaced, they're not going to do anything about it. Okay. One technical point to know about the clavicle is that you can often get this view where it doesn't look like it's very displaced on one view, but you need to do a tilted view just to expose how much displacement there really is for a clavicle fracture. But that's pretty much the only little trick with clavicle fractures. One thing I will say about the clavicle is that it's unlike a lot of the other bones we're going to talk about in the limbs, in that it's a place where metastases and myeloma tend to go to, all right? So this patient presented to ED after minimal trauma, and they've got a fracture through their clavicle, sent home, that conservative treatment. But if you see that there's some lysis around the edge of this fracture, so this was a pathological fracture, patient came in 2 months later, and that's what their lesion looked like. Okay, so that was breast cancer in a relatively young female patient. So that's one thing to remember for the clavicle. People do come and ask me about AC joint injuries because AC joint injuries can be a little bit hard to diagnose. I'm not one who really enjoys classification systems, but the important thing to know about AC joint injuries is that we do nothing for grade 1s and grades 2. Grade 3 is borderline in terms of getting a surgical fixation for it. If you're an athlete, they may go on and do some surgery. Definitely anything that's grade 4, grade 5, grade 6, they're going to repair. All right, so basically we want to try and determine what's a grade 3, okay? This patient has come in with a sore AC joint. They've got a grade 1 injury. Why? Because we don't really see very much and they're tender over there, so you're happy to give them a grade 1. There's a little bit of soft tissue swelling in the adjacent fat. But I just want to use them as a description of what a normal joint looks like and the kind of lines you want to be looking at. So we usually the clavicle should usually come over and articulate, obviously, with the acromion here. And the inferior margin of the clavicle should at least not sit above the level of the acromion. It varies a lot from person to person. Some people it comes along and it sits perfectly in alignment with the bottom of the acromion. Other people there's a little bit of superior displacement like this. It's really good to compare with the other arm. If it looks the same on the other side, then it's probably not significantly displaced. Okay. Weight-bearing images can be important for these subtle kind of injuries where there's not much displacement. Get them to load their arm and you'll see it might just jump up a little bit, okay? But the important thing is, does that inferior margin of the clavicle sit above the top of the acromion? If that's the case, then you've automatically got yourself a grade 3 injury, which may need surgery. Okay? The coracoclavicular distance is another thing you want to look at. Normal is about 10 to 13 millimetres. If you get an increase in that but not double that, then you're looking at a grade 3 injury. If you get double that, then you're looking at a much more severe end of the spectrum. All right. So here's an AC joint injury. Clearly this one is way above the level of the acromion here. And so that's at least a grade 3. This is probably doubling of that coracoclavicular distance, so it's probably a grade 5 injury to the AC joint. That's going to need repair. The reason why I love this case is because you see that little strip of calcification there. I'll show you that on the lateral as well. That little bit of calcification is where the coracoclavicular ligament inserts and has been pulled off. So these are the coracoclavicular ligaments. Has a trapezoid and a conoid component. But you can see how that inserts onto that little bit of cortex there. And so in that patient, the reason why that clavicle is allowed to displace up is because those ligaments have been pulled off the bone. So you'd think if you want to repair an AC joint, you should just repair that coracoclavicular ligament and everything will be fine. And that's what they can do, although it doesn't really give you full strength and stability in that joint. So these days, they tend to do a hook plate fixation for these things, where you put a plate across the end of the clavicle, hook it underneath the acromion. This gives you instant stability of the AC joint. People can get back into activities. If they're a footballer, they're pretty much back into it straight away. It doesn't stay in forever, the hook plate. It forms a scar tissue around it. Then the orthopaedic surgeon can go back in and remove the hook plate and the joint's regained its stability. All right. So that was the AC joint. Move on to the shoulder joint itself. Just a little bit of normal anatomy. The humeral head should always have a crossover with the glenoid on an AP projection of the shoulder. It usually forms this nice ellipse. They call it a half moon overlap. I'm not sure that's a great word for it, but it looks like that kind of ellipse. That's the normal appearance of an AP projection. When the patient internally rotates, you can see the bicipital groove comes across here. The humeral head starts to look like what we call a light bulb. Okay, that's normal if you've got your arm sitting in internal rotation. You get this very rounded look to the head. Okay, that's important later when we're talking about posterior dislocations. One thing that people often come and ask me about with the proximal humerus or the humeral head is they think maybe they've spotted a metastasis or a lytic lesion in the head. Can you see this lucency here? So we often get this pseudocyst or pseudo-lesion of the humeral head. That's completely normal. Okay, so that's one little trick to be aware of. Well, we're up to our first quiz case. And the winner for this one is Sen. Are you here, Sen? I haven't seen you. Come up. Round of applause for Sen. So this was our first case, and every single person who completed the pre-course quiz spotted that there was a fracture here of the greater tuberosity. Every single person, or most people at least, spotted that there was a dislocation of the humeral head. We've lost that semi-lunar overlap or half-moon overlap. The dislocation is antero-inferior in this case. But there was a third finding, and only a couple of people spotted it, and Sen was one of them. Do you want to point that out? That's all right, just speak loudly.
So there appears to be a lipohematrosis within the shoulder joint. You can clearly see that through an air fluid level.
That's correct. Well, that's very close to being correct. You can grab a bottle of wine or some food for winning that one. So that extra finding, he said air fluid level, but he meant to say fat fluid level. You can see that perfectly straight line here. Perfectly straight lines in the body is an interface of a gravity-related level. It can be an air fluid level, it can be a fat fluid level. So this is a fracture dislocation of the humeral head with an associated lipohemarthrosis. This is going to come back to us when we get to the knee, because lipohemarthrosis of the knee is a very important thing to recognise. This is my son. He's 4 years old, and he knows all about fat fluid levels. Okay. There's also the other level to recognise here is the air fluid level, because that comes back when we're talking about the chest and the abdomen later on. Okay, so these perfectly straight lines in radiology Gravity, important to recognise. You'll probably spot there's a little bruise here. That's not a defensive bruise. So that patient had an anteroinferior dislocation of the humeral head. And what that does is it can bang up against the inferior glenoid and create this little fracture down here called a Bankart lesion, okay, a bony Bankart. It can also impact the top of the humeral head and squash it in a little bit, and that's called a Hill-Sachs lesion. So this patient, just looking at this x-ray, you can tell they've had a previous anterior dislocation of the shoulder joint. MRI is important in the patients who've had recurrent dislocations to look for instability. Here's just what that Hill-Sachs lesion looks like. When they were dislocated, that would have been sitting right up here next to the front of the glenoid there. This is the Bankart lesion, is a tear at the front of that labrum. Okay, this is a cartilaginous one. You don't always get a bony fracture like we saw on that plain film. This is a cartilaginous one, still a very significant injury from an instability point of view. All right, a 40-year-old male involved in a motor car accident. And here we don't have a very nice half moon overlap. We're overlapping a little bit with the glenoid, but then we see the humeral head is extending up higher than we'd expect it to sit. We also see that it's got a little bit of that light bulb kind of appearance of the humeral head. It's very rounded so it's probably a little bit internally rotated. And then the other feature we're seeing in this patient is that the glenoid articular surface is lining up with this kind of, can you see this line along here? That's where it's formed a pseudo-articulation with the humeral head. It's called the trough line sign. So it's like the Hill-Sachs in the anterior dislocation, but this is a posterior dislocation forming the trough line sign. Okay, so this patient has a posterior dislocation of the glenohumeral joint. This is a lateral view or the Y view. The scapula forms this nice Y shape. The glenoid is in the middle of that Y, and you can see that the humeral head is sitting out the back. Posterior dislocations are quite difficult. This is just when the patient's now enlocated. You see you've got that nice elliptical overlap when the humeral head's back in its position, and nice centering of the humeral head within the middle of that Y on the lateral. We look at the CT in this patient. You can see here the equivalent to what we saw with the anterior dislocation happens at the back of the glenoid. You get a small avulsion fracture, so that's called a reverse Bankart lesion. And that impaction, that trough line sign that we saw on the plain film, or a reverse Hill-Sachs lesion at the front there. So exactly what you'd expect to see from direct impaction bone on bone from the dislocation. Here's a paediatric patient who again is presented with suspected shoulder injury, and you can see that nice kind of light bulb appearance to the humeral head. The humeral head should normally have a curve to it which matches the curve of the glenoid. You can see the glenoid here is oriented and looking very straight, whereas the humeral head's got a curve. So two structures that are articulating with each other should have a very similar curve, okay? So this is suspicious for a posterior dislocation, and if you look on this is a slightly different one. This is an axillary view or an axial view. You can see that humeral head has popped out the back. Here's the acromion, here's the clavicle coming across. The glenoid's going to be in here, okay? So that's the light bulb sign, posterior dislocation. A final one, just to show you that these are really hard. So this one doesn't look terrible, this joint, on the AP projection. There's a little bit of overlap, but it's maybe sitting a little bit funny, this glenohumeral joint. It's not quite following the same curve. You can see that curve there, not quite matching. It's a little bit of a light bulb on the lateral image. It's clearly dislocated out the back. Posterior dislocations are the tricky ones. This one I include only because it's got a really cool name. Does anyone want to shout out what this one's called? No. It always, when I hear this, it always reminds me of Harry Potter. And imagine if you can imagine, like, you know, Harry standing here and Snape's over here, and Harry, you know, Luxatio erecta, and then Snape is like, So these guys present with an arm that they can't pull down, right? This is an inferior dislocation of the humeral head, okay? Snape's in trouble if he's got one of these, okay? He's pretty much incapacitated. His wand is on the ground. Proximal humeral fractures, again, not many people come and ask me about these, so I'm not going to talk about them very much. There is a classification system, the near classification system. The important things to know about that is parts. It's all about parts. And basically, a fracture part involves greater than a centimetre or 10 millimetres of displacement of the fracture, or greater than 45 degrees of rotation of the fracture fragment, and then you just add up how many parts are doing that. Okay, so this one's not that displaced. Okay, nothing's really away, so that's just a one-part injury, even though the fracture is in multiple parts. Does that make sense? It doesn't make sense to me, so it shouldn't make sense to you. It's a very confusing classification system. This one is a great case contributed to our website of a patient who's got a very comminuted displaced fracture of their proximal humerus, clavicle fracture here as well. But the humeral head, can anyone spot where the humeral head is? I'll show you the CT. Here's the humeral head, sitting up in the thoracic cavity in the apex, and there they are fishing it out of his chest. That's obviously a many part near fracture of the proximal humerus. The last bit we'll do on the shoulder, in kids, you can get this lesion of the proximal humerus called a simple bone cyst or a unicameral bone cyst, and they can present with a pathological fracture. And you get the bone falling down. It's called the fallen fragment sign. The bone falls down into the centre of the cyst. Most lesions in the bone, like a metastasis or Ewing's sarcoma or all these other things, are solid tissue, okay? And if you break it, the bone can't fall down through the lesion. This one here is full of fluid, so when it fractures, it's just a simple cyst. When it fractures, that bone falls down and sits in the bottom. So if you get one of these presenting in ED and you spot the fallen fragment sign, you'll look awesome because you've picked a unicameral bone cyst. Okay. All right, time for a live poll question. So get out your smartphones. Which direction is this elbow dislocated? Is it anterior, posterior, or it's all relative, man? What do you think? So I'll just go back to the poll. Let's see. So we're getting a bit of a mixture of responses. We'll start with the... excellent. So the majority of people are going for posterior, and posterior is correct. The naming convention with dislocations is the same as it is with fractures. You're always describing the injury relative to the proximal bone. So the proximal bone is said to be in anatomical position, and everything else is displaced or angulated or dislocated relative to that, okay? So in this case, the humerus is here, the olecranon has fallen backwards, so that's a posterior dislocation of the elbow. It's all relative is probably a fairly good answer as well, because most of the time when you're describing these, you should say that the olecranon is displaced posteriorly relative to the humeral, to the distal humerus, so that people understand what you're saying. I do this quite often. So if you can just remember, if you were to say that the distal humerus is dislocated anteriorly relative to the ulna, that's a perfectly logical statement, okay? The convention is to say that this is a posterior dislocation. And this injury is called the terrible triad. It's a posterior dislocation in association with a displaced radial head fracture. You can see the radial head is sitting in here, completely displaced away from its normal location. And then the third injury is a coronoid process fracture. This is when the patient's been re-enlicated, but the radial head is sitting inside the joint. Obviously that needs to be fixed. All right, so some normal anatomy of the elbow. The elbow joint effusion, recognising elbow joint effusion is probably the key thing that I look for on an elbow radiograph. So I just want to teach you about that first. We've got lots of elbow videos on our radiology channel on YouTube, so I'd refer you off to those if you find that this is skipped through quite quickly. There's a little bit of fat at the anterior aspect of the humerus, which you can't really see in this patient. And there's fat that sits inside here. This is the olecranon fossa. Okay, see how this very thin bit of bone, that's the supracondylar humerus here, very, very thin. Okay, when you extend your elbow, this olecranon process comes up and fills up this space back here. That's why it's full of fat, so it can accept that. Okay, if you get a joint effusion, it's going to push the fat out of there. The fat obviously has to move a long way before you're going to see it out the back. All right, out the front, there's less distance for it to move, so you can detect a smaller effusion out the front. In terms of alignment, we're going to talk a bit about it with the paediatric elbows. There's an anterior humeral line which should go through the mid-third of the capitellum, and there's also a radiocapitellar line which goes from the radial neck, and it should also intersect the capitellum. So here's a patient with an elbow joint effusion, an adult patient. Okay, you can see that fat there. So the fat is a lower density than the surrounding musculature. Okay, subcutaneous fat here, nice low density. This is the fat that's been displaced from being in that little fossa at the front. It's been pushed out. This is called the sail sign of an elbow joint hemarthrosis or elbow joint effusion. Out the back, again, we've got this low density here. That's the fat pad, posterior fat pad being displaced. If you've got that out there, you've got a large elbow joint hemarthrosis. Now, it's a bit hard to see whether there's any injury in this patient. You look hard, you can't really spot anything. The most common cause for an occult hemarthrosis in an adult patient is going to be a radial head or radial neck fracture. So you'd be looking pretty hard. There may be some subtle sclerosis through here, bit hard to see. Patient came back, sorry, did I move on to the next one there? Patient came back a few weeks later, so 1 week later, and you can just start to see that sclerosis and maybe a little bit of overlap of the cortex at that neck. So the key to identifying that there was a fracture in that patient was the hemarthrosis, okay, looking for the sail sign. Here's another patient, this one's much easier, so elbow joint effusion here, sail sign, posterior fat pad sign, and you can see that there's a displaced fracture of the radial head. We do these kind of oblique views for the radial head, which often show it in much better detail than the standard AP and lateral projections, okay. There's a Mason classification for radial head fractures. 2 millimetres of displacement is the key to that one. If it's less than 2 millimetres displaced, they're not going to do anything about it. If it's more than 2 millimetres, they'll probably stick a little screw in it or a pin in it. If it's more displaced, if it's really, really displaced or completely off, then they'll often do a replacement of the radial head or a resection of the radial head. Okay. I'm going to a paediatric one. This is a 7-year-old patient who's fallen down. So same kind of thing here. Can you see that subtle low density here? It's not projecting fantastically there, but there is a subtle elbow joint effusion here. And you can just see a tiny little bit of fat projecting behind the posterior aspect of the humerus there. And you see this irregularity through the supracondylar region of the humerus, that bony irregularity there. That's a supracondylar fracture. So in paediatric patients, the most common cause of an elbow joint effusion in trauma is going to be a supracondylar fracture. In adults, it's going to be a radial head or neck fracture. Okay. The anterior humeral line is an important line in paediatric patients, which you draw down the front of the cortex of the distal humerus, and that line should go through the centre third of the capitellum. That's the capitellum. Okay. This one is going through the anterior third. That indicates that there's been a force pushing that backwards, supracondylar fracture. Okay. So if you see displacement of that line, even if you can't spot the fracture itself, posterior displacement of that line is a good sign that there's going to be a supracondylar fracture. There's the normal orientation, should go through the middle third of that capitellum. Here's another patient. This one I think is normal. I just want to point out that that anterior fat pad you can often detect if you're not seeing any fluid density or soft tissue density behind it, pushing it forward, because that's what the actual effusion is, right? It's that fluid density behind it, pushing the fat forward. If you're not seeing any of that, then there's probably not a joint effusion. So this, you can actually see the anterior fat pad in the setting of normality, okay? We're not seeing the posterior fat pad at the back here. In terms of ossification centres for kids at the elbow, we have a great video again on our YouTube channel about this, so I'm not going to cover it in great detail. But one thing to notice is that out here on the radial side, which is the lateral side, the lateral epicondyle often looks a little bit displaced away from the humerus. That's normal. Whereas the medial one, ossification centre, almost always, or does, overlap, or it should overlap with the humerus. That's worth noting. If you're seeing a medial one, this is the most common one to avulse. If you're seeing it not overlap with part of the humerus, then it's probably avulsed. There's a few mnemonics for remembering the elbow ossification centres. I've always used Crito, where it's capitellum, radial head. I means internal or medial epicondyle, trochlea, olecranon, and the external or lateral epicondyle. For some reason, a lot of people are turning towards Come Rub My Tree of Love to remember it, where M is medial and L is lateral. Depends how dirty you are as to which one you prefer. There's a numbering system for remembering the ages at which they appear. The basic one is 1, 3, 5, 7, 9, 11. Okay, so just going up in twos from 1. So this patient's going to be at least age 1 because they've got their capitellum. This patient's going to be at least age 3 because they've got their capitellum and their radial head, so on, so on. You can work out how old the kid is from that. Girls are going to be usually more advanced than boys in terms of their timing. That's why just having a rough numbering system, 1, 3, 5, 7, 9, 11, is usually adequate. Okay. The important thing is that the order of appearance is very set. Okay. So we'll have a look at this case here. This is a guy who, a 12-year-old who dislocated his elbow on the football field. They've put it back in, and here's what his elbow radiograph looks like. All right. So if we're going through in order, we're seeing that he has his capitellum here. He has his radial head. Okay, he should have an internal epicondyle, which we're not seeing. We're seeing his trochlea has developed. We're seeing his olecranons at the back. And then we're seeing his external epicondyle over here, okay, which is often displaced a little bit like that. So the important thing to recognise there is that he's got an external, he's got a trochlea, he should have a medial, okay? And this is where it is here, displaced away into the joint. As I said earlier, that's the most common one that's going to displace away. So that's important, worth recognising. All right, next quiz case. 6-year-old with a bruised and swollen forearm. What is your diagnosis? Shahina was our winner. Is Shahina here? Does Shahina want to come down and get a prize or not? You're going to miss out on a prize. Frank, it could be your moment. Frank, it is. Come on, up you come. Tell us about this elbow radiograph. All right, I'll help you out. So there's an elbow joint effusion. You can see that little fat pad. It's not great resolution, this image, but there's an elbow fat pad. There's a posterior fat pad out here too. And as we said earlier, there's that radiocapitellar line. So it's a line drawn through the radial neck, not quite through the shaft. The shaft is a slightly different orientation to the neck. So a line through the neck should go through the capitellar ossification centre, okay? So this is clearly a dislocation of the radial head. That works in all projections. So on the AP projection, again, a line through the neck of the radius should go through the centre of this capitellar ossification centre. This one is significantly displaced. So no prize given away for that one. Here's another one which is a little bit more subtle. You can see here they've got a green stick fracture of the radius. You can see that there's a fracture line on the cortex here. I'll just zoom in even more for that. Fracture line here, but the other cortex is intact. So it's like a twig, a young twig, a young sapling. When you bend it, one side snaps, the other side just bends and doesn't fracture completely. So they've had a green stick fracture of the radius, and you can see that if you draw that line from the radial neck, it's not going through that capitellum there. On this projection, it goes through not too bad. On the lateral here again, through the neck, it's not going through the centre of that capitellum. So radiocapitellar line. Everyone knows as soon as you start talking about radial head dislocation, the next thing people want to talk about is the Monteggia fracture. So here it's a fracture, displaced fracture of the ulna associated with a radial head dislocation. There's a few mnemonics for remembering this one. Mugger is not a bad one, so it refers to which bone is fractured. So Monteggia is an ulnar fracture. The Galeazzi injury, which we'll see in a moment, is the radius that's fractured. Grimace is just an extension of that. So Galeazzi is a radial fracture and it's the inferior, so it's inferiorly, so distally. And Monteggia is an ulnar fracture and it's a superior dislocation. Okay, so proximal dislocation. I always remembered Uncle Monty. So, you know, if it's an ulnar fracture and a radial head dislocation, that's a Monteggia fracture. Here's the Galeazzi, so a fracture of the radius with dislocation of the distal radioulnar joint. You can see that it's overlapping all these carpal bones here. Clearly, this joint is very dislocated distally. We're going to talk about descriptions of fractures at this point because it's often one thing that interns or residents need to know in order to describe it to the orthopaedic doctors over the phone. So I thought I'd choose this case for it. So we've got clearly we've got a transverse fracture here, so it's going straight across. of the distal radius. This area here is the growth plate, the lucent area, that's cartilage. The next little bit is the metaphysis. Then it forms the diaphysis, which is the shaft of the bone. And the junction between the two you call the metadiaphysis. Okay, so this is a transverse fracture through the metadiaphysis. In terms of displacement, we can see that it's dorsally displaced. Again, we're assuming that this proximal portion is in anatomical position and everything else is dislocated or displaced relative to that. So you can see that the radius here, the metaphysis is displaced dorsally by about the width of the shaft. Okay, there's shortening. You can see overlap, so the fracture is here and then the other end of the fracture is here. So there's shortening of the fracture. If the fracture impacts into itself, that's called impaction. So if the bone actually goes into itself and that causes the reduced length, that's called impaction. But if it displaces away and then moves over each other, that's called shortening of a fracture. And then it's obviously displaced in the other direction. It's also displaced in the radial side, okay, or laterally. Okay. So displacement dorsally and laterally by the width of the shaft, shortening, and then there's a corresponding fracture of the ulna, which is a little bit bendy here. That's called a torus fracture. Can't quite see a fracture line. It's just done a little buckle. Okay, so torus fracture or buckle fracture of the ulna. Again, there's angulation. Angulation you would describe relative to the proximal portion. So this distal radius is angulated towards the radial aspect or laterally relative to that. Anything else, Andy, that you can think of with describing fractures for surgeons? I think intra-articular extension is the other thing. This one's nowhere near the joint.
Other issues are open or closed. You can't see on the x-ray, but it's a crucial point the orthopaedic surgeons want to know because that'll determine how quickly they come and see the patient. Open fractures get seen immediately and go straight to theatre. And people often forget to say it. They don't take back slabs off before they x-ray. That's a bugbear of mine. Take the back slab off because you'll get better pictures and you'll also see the injuries. And we're also going to say, if there's a potential neurovascular compromise or limb threat associated, add that onto the referral while you're describing it. If you Google ED exam fracture, that's my other blog, I've got a post there about how to describe fractures. It says for written exam answers, but you need to have that template in your head when you're referring fractures over the phone.
Okay, thanks Andy. So we'll move on to the next one. I've written a full description for that on the website. So when you play through this, you can have a look at my very wordy description of that fracture, just to get an idea of the kind of words that a radiologist would use to communicate that injury. All right, so we'll practice that again. Here's an older patient who's fallen down and they've fractured their distal radius. You can see that there's a transverse fracture line going through here. You can see that the ulna extends further distally than the radius. Okay, that's the radial articular surface there. That's the other side of the radius there. You can see that this is further distal than that. That's called positive ulnar variance, and that's a sign that this is an impacted fracture. If you look on the lateral, you can see how that bone is just compressed into itself. Okay, so impacted. You can see some angulation here, so the bone's coming along, and then this part of the radius, the distal radius, is angulated dorsally relative to that. So transverse impacted fracture of the distal radius with dorsal angulation. Important thing is to look for intra-articular extension, looking along this margin here and seeing that you're not seeing any displacement, there's no cortical step along there, there's unlikely to be an intra-articular extension of this fracture. Look at that perfect line out the back, and in between you're not seeing any lucent line running to the surface. Okay, so non-intra-articular fracture. Quiz case number 3, 30-year-old male who fell and has wrist pain. Describe the injury. Bridget was the winner. Is Bridget here? Does Bridget want to come down? You get a prize. Yeah, she's coming down. I'll start going through it. With this case, probably about everyone with this case spotted the fracture of the distal radius. This one's through the radial styloid. Okay, fracture here, a little bit comminuted, so it's in parts comminuted, and it's definitely extending into the joint. You can see a slight disruption of the articular surface here, so an intra-articular fracture of the distal radial styloid. Okay, the extra finding, and the one that allows you to win a prize, is if you spot, and what Bridget spotted, the widening of this scapholunate interval here. Okay, So the scapholunate interval is not allowed to be any wider than 4 millimetres. Usually it's around 3 millimetres. This one's at least 5 millimetres. Okay? So there's been disruption of the scapholunate ligaments. If you disrupt those ligaments, the capitate eventually starts to migrate forward. You get degenerative disease of your wrist unless you repair those ligaments. Okay? So this is an important injury. This fracture is not very displaced, so they're probably not going to do anything for this patient from a fracture point of view, but spotting that ligamentous disruption, that scapholunate widening, is the important thing. Bridget, you can get a bottle of wine. Here it is on CT again. Fracture, it's not going to be managed with operation because there's no real step in the surface, okay? But that widening of the joint. They call it the Terry Thomas sign, the David Letterman sign, the Madonna sign, all referring to the fact that those people have widely spaced front teeth. Okay. So here's a normal wrist. I just want you to have a look at the joints, okay? Every single joint in the wrist has a very, very similar amount of joint space, okay? So here we have, the distal radial, the radiocarpal joint here, scapholunate, articulation here. Every single one of these is a very, very similar distance, just a couple of millimetres. Doesn't matter which joint you spot, okay? They're all just a couple of millimetres, all right? So it's important to look for on a normal wrist radiograph. They also have this, this line, a nice arc. You see here, this mid-carpal line, a nice arc, okay? Down here, proximal carpals, a nice arc, okay? The lunate here, which is this bone here, will often overlap just a tiny bit with the capitate, okay? That's normal, but there shouldn't be a lot of overlap, okay? The carpometacarpal joints, again, is kind of this jagged kind of joint here. You don't want to see too much overlap of those metacarpals with the carpal bones, okay? Just a little bit, not a lot. On the lateral projection, the most important thing to look at is that the distal radius is articulating with this lunate here, which is a moon-shaped bone, okay? And that is articulating with this bone here, which is the capitate, all right? That's the main thing to look for on the lateral. Also, looking that none of the metacarpals, they're all kind of line up quite well. They overlap each other on the lateral image. If you see one that's not overlapping with the others, then that could be a carpometacarpal joint dislocation. That's the normal anatomy of the wrist. Here's a case or a patient who's fallen over, and you can see they've got an ulnar styloid fracture here. But in terms of looking at our lines, we have not a bad line along here, but we've got disruption of this normal line along here. You can see it elevates there. And then you've got way too much overlap of the lunate over the capitellum. They call this the piece of pie sign. Kind of looks like a Trivial Pursuit piece of pie, okay? So if you get a triangular shape to the lunate on an AP projection of the wrist, that's a sign that you're going to be dealing with a dislocation, okay? It could be a lunate dislocation, could be a perilunate dislocation. Important to then go and look at your lateral, and you can see here's that distal radial articular surface, which should have a nice corresponding lunate, but instead that lunate is sitting out at the volar aspect of the wrist, or palmar aspect. It's no longer articulating with the distal radius, and it's no longer articulating with the capitate. Okay, capitate and the radius still in the normal alignment. So that is a lunate dislocation. So the other one, that's the piece of pie sign. The other one is the perilunate dislocation. This is often harder to spot and is often associated with a scaphoid fracture. You can see this patient here. This is the scaphoid. This is all the scaphoid. You've got a very displaced, slightly comminuted fracture through the scaphoid waist. This is going to need to be surgically repaired because of the risk of avascular necrosis, which we'll come to shortly. You see this abnormal overlap of the scaphoid here with the capitate. Probably too much overlap of the lunate as well. The lunate is also overlapping with the triquetrum over here, which is not what it should do. You should see a nice little joint between the two. If you look on the lateral image, this is different to the last case. You can see that the proximal aspect of the lunate is still articulating with that distal radial articular surface, but the distal articular surface of the lunate is no longer communicating, articulating with the capitate. Capitate is dislocated dorsally out the back here, okay? You see that? So that's a mid-carpal dislocation, perilunate dislocation. Capitate has slipped off the back relative to the lunate. Okay, associated with other fractures very, very frequently, particularly a displaced fracture of the scaphoid. The important thing about these lunate and perilunate dislocations is that you can often put pressure on the nerves and arteries running at the palmar aspect of the wrist. And so it can be an orthopaedic emergency to get that joint back into alignment, okay, in order to preserve function of those nerves and those vessels. So important to recognise it and not leave it for too long. That's a CT just demonstrating exactly what you see on the plain film. Lunate still articulating with the distal radial articular surface, capitate sitting way out the back, big displaced fracture through the waist of the scaphoid. Okay. Let me see what we're talking about here. We're moving on to scaphoid fractures now. Scaphoid fractures, as you all know, are very important because if you fracture through the waist of the scaphoid, the blood supply typically comes in through this junction between the waist and the distal pole and supplies the proximal pole of the bone. If you fracture through the waist and you do it with significant displacement, then that can disrupt the blood supply. That proximal pole of the bone becomes devascularized and you get avascular necrosis in there. So it's important to recognise these fractures and to manage them adequately so that it doesn't become more displaced and result in avascular necrosis. They can be very hard to spot, very subtle scaphoid fractures. You can do focused views if you write scaphoid views. If you write snuff box tenderness or question mark scaphoid fracture on your X-ray request, the radiographers should go on and do these specific scaphoid views, which often give you much finer detail as to the fracture and can give you a better idea as to whether there's a fracture or not. Now, one question that we had from the international audience was to do with management of suspected scaphoid fracture with a normal X-ray and what the management for that would be. I think there's a few different ways to skin the cat on this one, and all of the methods work quite well. You can get a CT straight away, which will probably show you the fracture, okay, but there's a little bit of radiation exposure with doing a CT. But when it's peripheral exposure of radiation, it's a very, very low dose. You can assume there is a fracture and just treat it like that and then get an X-ray in 7 to 10 days and you might see a little bit of sclerosis or the fracture line becomes more obvious. Or you can do an MRI, would be the other thing, to look for marrow edema, and you can often see the fracture on that as well. With paediatric patients in Australia now, there is the rebate for suspected scaphoid fracture for getting an MRI. So that would be probably the way you'd go in kids, get the MRI. In adults, you'd probably be getting a CT, or assuming there is a fracture and getting them back to fracture clinic with a repeat X-ray in 7 to 10 days. Here's the CT on that patient. CT can be important, and this is one reason to do a CT rather than a bone scan. CT can be important because you can detect whether there's any volar angulation of the fracture, and you can develop a thing called a humpback deformity of the scaphoid, and that can alter the whole biomechanics of the wrist and result in dysfunction. If you don't do the CT and don't recognise that, then you might be doing non-operative management on someone who really did need to have operative management. Here's a patient who had an unrecognised scaphoid fracture and it was significantly displaced, and they've developed avascular necrosis of the proximal pole of the scaphoid. See that little dark area? This is the normal fatty marrow signal within all the other bones. On the T1 weighted MRI, proximal pole has become dark. On the fat-saturated fluid-sensitive sequence, you can see there's edema in that proximal pole. Starting to get degeneration of the joints around there, the cartilage is being lost, and you're getting edema in some of the other carpal bones as well. All right, so that's why scaphoid fractures are important. So Ian, in the UK, we allowed our online audience to pre-submit some questions for this course, just to help direct us with some clinically relevant things. And he asked us, how old do you have to be before you can actually fracture your scaphoid? And I didn't really know the answer to this. All I knew is that I don't see them in kids at all. You see them in teenagers and you see them in adults, young adults. That's the main kind of age group for scaphoid fractures. I've asked a paediatric radiologist who says he's seen one as young as age 9. Okay, but if you're talking really young kid and you're going question mark scaphoid fracture, you're very unlikely to see it. It's much more likely to be a a buccal fracture of the distal radius. That's what you see in kids. All right. This one is cute. This is a patient who's fallen down. And on the lateral image here, you can see this little bone fragment just displaced out the back of the wrist. Okay, so dorsally, a little bone fragment. You can see that you've got your lunate here, seems to be intact. You've got your scaphoid, which is coming around like this, seems to be intact. The only other bone in the proximal carpal row is the triquetrum. Okay, and this is what a triquetral fracture looks like every single time, a little bone sitting out the back. Okay, so if you see that, you don't need to think too hard about what it is. That's a triquetral fracture. It's not significant, but it's cute to be able to say, oh, that's a triquetral fracture. Looks the same every time. All right, so this guy, this is a 55-year-old fallen from his bike. He's got pain at the 4th and 5th metacarpal shafts. Now, this is the kind of injury that is very frequently missed by the emergency department staff and can often be even missed by a radiologist because it's relatively subtle. But remember when I spoke earlier about that line of the carpo-metacarpal joint? Should be a line coming across here, and you shouldn't see too much overlap between the base of the metacarpal and the other carpal bones. That's correct for the 2nd, 3rd and 4th metacarpals in this patient, but you see this 5th one seems to be sitting way proximally relative to the other ones, and it's overlapping, okay, with the hamate. And then when you look on the lateral projection, remember I said on the lateral projection, you want to see all those metacarpals overlapping with each other. You don't want to see one jumping out the front. Obviously the first metacarpal is the exception because of our nice ability to grasp things. But this is the 5th metacarpal here, and you can see it's sitting way out the front compared to the other ones. So that is a dislocation of the 5th carpo-metacarpal joint. Often missed, obviously important to recognise, get it back in, everyone's happy. Time for a poll question. So get your phones out again. Hopefully the poll's been triggered. Now this one, the patient's obviously had a little bit of fun with a nail gun and has managed to get the nail to pass through their thumb. And what I want you to do is work out whether you think this nail is passing through the bone, yes, no, or you can't tell based on these images. Okay, so we've got, so not many people are thinking that it goes through the bone. 22 people say that it's not going through the bone. Quite a few people say you can't tell. All right, so let's have a look at it. Now there's a bit of a misconception among some people that if the object projects through the bone on both views, on 2 views, then it must be going through that bone, which is completely incorrect, okay? You can only say that if you have one view that is completely tangential, basically angling straight down the end of the nail, okay? Or so imaging the nail on the head, so to speak. In this case, you can tell that this one doesn't go through the bone because if you have a look here, so if you assume that this is going through the bone here, then that's where it should be going through on the nail, okay? You go onto this one, measure the same kind of distance out, it should be going through bone here, okay? So if you think about it in terms of which bit's going through the bone, does it look the same on both images, you can get a better idea. Clearly there's no fracture here as well, which you'd expect to see if there was a nail going through the bone. But I think that's worth knowing. Try and get your radiographer maybe to shoot directly down the line of the nail if they can. That gives you the best answer. Otherwise, think about it in terms of where is it going through the bone. And often you can't tell, but in this case, I'm pretty sure that that's not going through the bone. This is a good history. Punched someone's face, now saw thenar eminence. 17-year-old male. They're always male, these patients. Okay, this is a nice little case that I show to the radiology registrars as they're about to take their exams. It's the kind of case where it really blows their confidence. Because as soon as they see this case, they're going, oh, I know this. Base of the first metacarpal, it's a Bennett or it's a Rolando, and the trick is that this one's neither of those, okay? So Bennett's fracture, Rolando fracture have to be intra-articular, okay? So this doesn't go into the joint, all right? So this is just a fracture that is nowhere near going into the carpometacarpal joint. It's still a significant fracture. It's called an epibasal thumb fracture or a pseudo-Bennett's fracture. Okay? And the point is that it's displaced, and the thumb is an extremely important tool for human beings, and so a fracture even displaced by this amount needs to be fixed. Okay, so it's just a good one for tricking the registrars who are, as soon as I show it, you see their eyes, they're like, oh, which is it? This is a Bennett's fracture, so this is clearly intra-articular. What happens with a Bennett's fracture is that little fragment here remains in articulation, okay, with the carpal bone, but the rest of it dislocates or subluxes out, okay? I think it's abductor pollicis longus that continues to pull on that bone, okay, and causes the subluxation. So that needs surgical fixation. The other one is the Rolando fracture, which is just the same as this but comminuted, okay? Again, needs surgical attention. The thumb is very important, and we're going to finish with this final injury. So this patient has this little bit of bone which has been avulsed from the base of that first proximal phalanx, okay? At the ulnar aspect, this is the radial aspect out here, the ulnar aspect. So you have an ulnar collateral ligament that goes from one side to the other, and if that ligament pulls, it's going to avulse a little bit of bone there, all right? Now the important thing about this ligament is that it's essential to the function of that joint, and if the ligament is torn and displaced and gets stuck anterior or above the adductor aponeurosis, then it doesn't heal up. So if a ligament stays in its normal kind of position, it's going to heal up, it's going to scar, and you'll get most of your function back, doesn't need a surgical repair, okay? Even with this fracture, it's likely that that'll heal up, the fracture will unite, okay, and you'll get the stability back into that joint. But if you have a look at this, here's some diagrams from Frank. Back in 2009, Frank used to draw diagrams. He has to have a lot of time on his hands. So this is the ulnar collateral ligament here. Here's it tearing. You don't have to pull off a bit of bone. In fact, if you pull off a bit of bone, that's a good thing, because bone's very good at healing itself back down, okay? Ligament, not so good at healing itself, okay? If it pulls away and the ends of the ligaments remain fairly attached to each other, it's going to scar up. You're going to get most of your stability back in that joint, not a huge issue, okay? But here is the adductor aponeurosis, okay, which comes across, passes superficial to the ligament, and then fuses with those extensor hood of that finger, of the thumb, okay? Now what happens is, in some situations, that ulnar collateral ligament tears and it flicks superficial to that adductor aponeurosis. If that's the case, there's no way for that ligament to join back up with itself and form a nice scar. Okay, this is always going to be unstable, this joint. It needs a repair. And if you don't repair these joints, you get severe osteoarthritis and you can't use your thumb. Okay, so this is critical to identify. So if you get a plain film, someone who's injured their first metacarpophalangeal joint, and the plain film looks pretty normal, but you think, he's a bit sore and maybe there's a little bit of mobility there, you really need to get an ultrasound or an MRI to look for, firstly, an ulnar collateral ligament tear, but also what this is called a stena lesion, where the ligament is flipped superficial to that adductor aponeurosis. I can show off my MRI skills and point out that on MRI for you. So this is the ulnar collateral ligament here. It should come and join onto the bone at the base of the first metacarpal here. First proximal phalanx here. But instead you've got this thing, this is the adductor pollicis. You can see the aponeurosis comes across here. And you can see that bunched up, torn ligament is sitting superficial to that aponeurosis.
Andrew, it's important to not order stress views, is that right?
Yeah, I think stress views is important to not order because you can actually cause that ligament to sit superficial, all right? So it might have been sitting in a nice spot and going to scar up well. If you stress it, the ligament can pop superficial to that adductor aponeurosis and cause the stena lesion. Okay, so you can see it again on the axial images here. Here's the aponeurosis. Follow that black line there coming from the muscle belly. Follow that black line here. It's passing deep to this torn ligament here. Okay, So you don't need to know how to recognise this on MRI, that's the radiologist's job, but you do need to know this is a very important joint. If someone's injured it and the x-ray looks normal, I would like to do an ultrasound. You can see this very well with ultrasound, or an MRI, just to ensure there's no significant lesion and doesn't need a repair.
Can I just reiterate that point, because I think in the old textbooks they used to say you can, because you can't do stress views on the first day anyway because these are too painful, but I still see people getting sent around to radiology asking for stress views on the day of the injury, which is mad because it's just painful. And I think some of the old textbooks used to say, oh, inject some local and then send them around for stress views, and I think that's just a double.
I think the injury is so significant that it doesn't matter what your stress views show, you're going to do an ultrasound or an MRI to confirm that it's there or it isn't. All right, that's the end of the upper limb section. We'll just have a 2-minute break just to stand up, stretch. You can tweet if you want. These boys have been on Twitter. So literally just 2 minutes because we'll get on to the lower limb section.